Our next speaker is Dr. V. Sreelatha. Madam is MD, Anesthesia, DGO. Madam is instructor to AHA and ACLS and BLS. She is Associate Professor, KMC Kurnool Medical College, Andhra Pradesh. Madam's field of interest are labor analgesia and pediatric anesthesia. Her achievements, she's been secretary to the city branch, Vijayawada, and during her tenure, it has got the best city branch award, and she has many publications and paper presentation. Welcome you, madam.
Good morning to all. So let me say thanks to organizing committee for giving me the opportunity. My topic is symptomatic post-COVID-19 variant posted for Lscs. So we have faced so many hurdles and panic situation during COVID-19 pandemic. So we stayed away from our family members 7 months and together. So being anesthesiologist, we should be proud of overcoming the COVID-19 pandemic. So coming to objectives of my topic, so pathophysiology of COVID-19 and physiological changes of pregnancy. So what are the pathological changes due to COVID? So effects are both on mother and fetus. So what are the investigations before we take in the patient? So monitors and management, regional versus general anesthesia. So introduction is novel coronavirus is a single-stranded RNA virus belongs to SARS-CoV-2. The first case was detected at Wuhan, China during December 2019 from bronchoalveolar secretions. So the mode of transmission is contact droplets. Aerosol spread if we are taking during general anesthesia. Incubation period is 2 to 10 days. So incidence of COVID-19 in pregnant is 14.43. As pregnancy itself is immunocompromised state, so Pauterian patients are affected more than normal women. So what is the pathophysiology of the COVID-19? So COVID-19 affects all organs, but mainly lungs and liver. It damages endothelial of the pulmonary vasculature and causes hemorrhage, thrombi, and it leads to ventilation perfusion mismatch, so may lead to hypoxia and refractory aortis. As the liver has dual blood supply, like hepatic and portal, so it is also affected. So it causes liver enzymes and thrombocytopenia. So myocarditis, renal failure or sepsis can also be seen. So what are the etiology for physiological changes during pregnancy? There may be hormonal alterations. So increased demand of feto-maternal circulation and pressure effects due to gravid uterus. So coming to cardiovascular changes, so there may be increased cardiac output, increased blood volume by 35%. So there is disproportionate increase of plasma volume and cell volume. So that leads to hemodilution. So because of the pressure effect of gravid uterus on the inferior cava, it may lead to supine hypotension syndrome. So coming to respiratory system, so there is upward displacement diaphragm by the fetus, and also there is decreased FRC. So that finally leads to patient more prone for hypoxia. So coming to gastrointestinal system, so because of increased progesterone levels, the tone of lower esophageal sphincter will be decreased. And also there will be increased intra-abdominal pressure that both leads to increased risk of aspiration. Coagulation system, so factor 2 and 5 are unchanged. So there is increased levels of factor 7, 9, 10, 12. So increased level of fibrinogen and platelets. So pregnancy itself is a hypercoagulable state. So it is further precipitated by COVID-19. So what are the effects of COVID-19 on both mother and fetus? On mother, the hypoxia, ARDS, DIC and hepatic or renal dysfunction. On fetus, it may lead to abortion, premature births, IUGR, childbirths and perinatal mortality. So coming to what are the signs and symptoms of COVID-19? As we all know, so fever, dry cough, myalgia, running nose, loss of smell and taste, diarrhea, pain abdomen, headache, even difficulty in breathing. In severe cases, there may be symptoms of pulmonary edema. So coming to treatment, so symptomatic treatment, so paracetamol, azathioprine, but during pregnancy, we have to give low molecular weight heparin, that is enoxaparin 0.5 to 1 milligram per kg per day, but should be continued up to 10 days postpartum. So, taking history is very difficult as patient is very infectious. So, we have to take history by telemedicine or filling proformas or online counseling. So, we have to, patient is posted means we have to examine the airway so that we can plan for that, either general or spinal. So, we have to examine the airway by video or webcam or keeping a glass shield between the patient and the healthcare provider. Coming to investigations, so routine investigations like RT-PCR, rapid tests, hemogram including CBC, as there is disproportion of increase of lymphocytes, neutrophils. So random blood sugar, even though at young age patient is not diabetic, but it is very important because so there may be abnormal levels of blood glucose levels, as COVID affects the pancreatic also. Then liver function test, renal function test, ECG, 2D echo, to know any involvement of heart or any QT prolongation due to chloroquine therapy. Then blood grouping. So ultrasound lung. Depending upon the CORAD levels, we will know the severity of the disease. So if at all it is necessary, his HRCT can be advised along with shield. So inflammatory markers like D-dimer, C-reactive protein, LDH, ferritin, troponin, procalcitonin, interleukin 6 and 8, or will be elevated if the disease is very severe. So coming to coagulation profile, prothrombin time, INR and thromboplastin will elevated. There may be, because of the involvement of liver all, there may be decreased levels of platelets. So we have to assess the type of anesthesia. If it is platelets decrease more than 50,000. So if the patient is hypoxic, we may order ABG to know the levels of oxygen, carbon dioxide. So depending upon that, we can decide whether NIV is advisable or invasive. Care of the patient during, it is very task to take the patient to the theatre. So there are so many difficulties shifting and taking to the theatre. The care of the patient during shifting is, carriage should be maintained green channel, so no one should be there. So experienced healthcare provider should be available while shifting if there is any hypoxic condition. So prevention of transmission, keeping a separate lift boy to switch the lift buttons all like that. So patient should wear surgical mask. Care of the patient during shifting to the theatre from negative pressure chambers. So coming to, so patient should be taken electively, suggestible. So if it is emergency means we should be rushed. So we have to take care of all personal protection equipments. So better to take as elective case. So coming to theatre preparations, separate isolated COVID theatre should be maintained. So experienced healthcare professionals should be there to look after all the events. So we have to minimize the number of persons to curtail the aerosol generating procedures, and also we have to minimize the instruments also. If at all we need it, we have to keep an assistant with some instruments outside the theatre. Then protection of workstations all by decontamination and transparent drapers and using filters. So management. Depending upon the severity of the disease and coagulation profile, general anesthesia or regional anesthesia we have to decide. So as regional anesthesia associated with more droplet infection, so it may be epidural or spinal anesthesia. So keeping early epidural catheter is the preferable. So if at all it is necessary, we can go for surgery also. So as general anesthesia associated with aerosol spray, we have to take more precautions. So coming to general anesthesia, so the healthcare provider should wear PPE kit, N95 mask, double gloves. So preload is very critical, as lungs are already, pregnancy itself is hyperdynamic condition. It is further aggravated by COVID-19. So preload should be very careful, 5 to 10 ml per kg of crystalloids. So under aseptic conditions, 1.8 to 2 cc of 0.5 bupivacaine are heavy, deposited in between L34 or L45 with 25G quinquenadine. So what are all the various monitors we have to conduct the patient? The pulse oximeter, NIBP, ECG, ETCO2, urine output. So coming to general anesthesia, it is associated more aerosol spread. So we have to take extra precautions like powered air purifier respirator, face shield, and water resistant dress and like shoe legs. So we have to pre-medicate the patient with the glycopyrrolate, midazolam, fentanyl, ranitidine, and metocarbamate, as patient is itself is more prone for acid aspiration syndrome. So we have to pre-oxygenate, as they are more prone for hypoxia due to this COVID effects and all. We have to pre-oxygenate for 3 to 5 minutes, 100% oxygen. So we have to allow the patient to take spontaneously. So we have to avoid positive pressure ventilation during this pre-oxygenation patient, particularly in COVID situations. So induction with thiopental sodium 3 to 5 milligrams per kg or propofol depending upon the vital conditions. So we have to maintain Celix maneuver, rapid sequence intubation. So intubation should be done with video laryngoscope under SCOLI 1.5 to 2 milligrams per kg. So immediately after intubating, you have to clamp the tube and HME filter is connected. Then only after cuff is inflated, then only we have to ventilate. So position of ET tube confirmed by chest rise and ET CO2 monitor. As normally we will confirm by bilateral, checking bilateral entry, but it should be avoided during this time. So maintenance oxygen nitrous oxide 50-50 up to the delivery of the baby. Then we have to change 60 to fasting. So we have to give inhalations as in like sevoflurane and vecuronium or eteroconium depending upon the condition of the mother. So extubation, as it is very infectious, we have to take very carefully. So we have to avoid cough and we have to maintain closer suction. So if at all possible, we have to keep wetted mask on the tube. So we have to reverse the patient by giving neostigmine 2.5 grams and glycopyrrolate 0.1 milligram. So as cardiac failure chances will be more immediately after delivery, we should be very cautious. We have to monitor the patient. So coming to care of the baby, placental transmission is very rare, but there is no contraindication to breastfeeding. But mother should wear mask during feeding. So postoperative analysis, patient is shifted to separate COVID postoperative care unit. So as we all know that analysis may be multimodal. If at all patient is already on epidural catheter, we can give analysis through that. So maybe we may give tab block or fentanyl patch or IV fentanyl. So pain management paracetamol we can give 1 gram 8th hourly, or if there is no contraindication we can give NSAIDs also. So thromboprophylaxis with enoxaparin should be continued 10 days after postpartum. So what is the discharge criteria? When will you discharge the patient? So discharge is recommended as per the following guidelines. So lung lesions significantly reduced in area completely absorbed or resolved. A few strips are present, no new lesions found. So after discharge, we have to recommend the patient should be have a 15 days self-monitoring for health or CT re-examination if necessary. So in our institute, Kurnool Medical College, during 2020, we have given 379 spinal cases. So summary of my topic is COVID-19 infection may be mild to severe. If diagnosed early, recovery is good. COVID-19 virus affects both mother and fetus. Preparation and shifting of the patient is important. So type of anesthesia depends on general condition of the mother. A residual anesthesia is the better choice. So general anesthesia is associated with the risk of generation of aerosols. So these are my references. I experience in a dedicated tertiary care COVID facility in Western Uttar Pradesh. So as the material is somewhat, so I have given only these small references. So that too COVID-19 is recently we have known. Anesthesia considering for pregnant people with COVID-19 infection. Then anesthesia experience in COVID-19 positive patients delivering by cesarean section, retrospective single center cohort study. Thank you.